بسم الله الرحمن الرحيم. بسم الله الرحمن الرحيم. بسم الله الرحمن الرحيم. صباح الخير جميعا. بنرحب بكم في اليوم الثاني المؤتمر الهيئة التعليمية، مؤتمر هيئة المستشفيات التعليمية والمعاهد التعليمية لطب الطوارئ. ان شاء الله الجلسة دي عنوان الجلسة هو بوست ترانسبلانت emergencies. الاول بس يسعدني احنا نقدم التشير بيرسونز اللي معانا. طبعا اولا نحب نقدم الدكتور محمد صلاح، العميد السابق لمعهد الرمد لابحاث معهد التذكاري للابحاث الرمديه، وامين عام الهيئه السابق، واستاذ الرمد بالمعهد. بعد كده بنقدم الدكتور محمد اسماعيل سليم، هو العميد السابق لمعهد القومي للكبد والامراض المتوطنه، ومؤسس برنامج زراعه الكبد بالمعهد، والعميد السابق للمعهد ايضا. بعد كده بنقدم الدكتور عبد الفتاح حجازي، استاذ الدكتور طبعا كلهم اساتذه، مدير مستشفى الساحل التعليمي، ومؤسس برنامج زراعه الكبد بمستشفى الساحل. ثم بنقدم الدكتوره حنان الغنيمي، استاذ الدكتوره حنان الغنيمي، عميده المعهد التذكاري للابحاث الرمديه. وبعد كده معانا الدكتور طارق فخر، طبعا الاستاذ الدكتور طارق فخر عضو اللجنه الفنيه لزراعه الاعضاء بوزاره الصحه، والعميد السابق لمعهد القومي للكلى والمسالك البوليه، هو استاذ الكلى والمسالك البوليه وزراعه الكلى طبعا. ومعانا دكتوره هبه فضل، استاذه الدكتوره هبه فضل، استاذه الكبد والجهاز الهضمي والمناظير وزراعه الكبد بالمعهد القومي للكبد والامراض المتوطنه. واخيرا وليس اخيرا الدكتور محمد عبد الوهاب الابجيجي، استاذ الكبد والمناظير والجهاز الهضمي وزراعه الكبد بالمعهد القومي للكبد، ونائب رئيس الهيئه العامه للمستشفيات والمعاهد التعليميه السابق. هنبدا ان شاء الله اول محاضره، هنسيب التشير بيرسونز بس يقدموا اول محاضره ان شاء الله مع الاستاذ الدكتور احمد حلاوه. شكرا.
صباح الخير. يسعدنا طبعا تواجدكم في المؤتمر الهائل، والحقيقه بحب اشكر كل المنظمين على راس المؤتمر، طبعا الاستاذ الدكتور محمد مصطفى رئيس الهيئه وجميع المنظمين. We will start now to start first session today. Professor Ahmed Halawa, a professor of nephrology in England, and he is one of the most membership and also famous person in renal transplantation. We'll talk about graft nephrectomy, immunological risks.
Today I'm going to discuss with you graft nephrectomy versus no graft nephrectomy. The objectives of our talk today is mainly directed to those patients who are potentially fit for retransplantation, because it makes a difference whether we do graft nephrectomy or no graft nephrectomy, especially in asymptomatic patients. Also, we'll discuss whether we need to give immunosuppressive drugs following graft nephrectomy or no need for immunosuppressive drugs. We all know that immunosuppressive drugs are associated with morbidity and mortality. Shortly, I'm going to present here the cross-match report of a highly sensitized patient. She presented to us for the second transplant with calculated pan-reactive antibodies of 100%. She was delisted. Basically, we removed the less significant antibodies from her profile in order to get her a kidney offer. She has been on the waiting list for the last 4 years after failed renal transplant, which was removed next day. Finally, she received a deceased kidney offer from a 23 years old DBD donor with excellent kidney function who died from hypoxic brain damage following hanging. This is the cross-match report, and as you can see, the current cross-match was reported negative for both T and B cells. However, historically was positive, most likely due to either the transplantation itself or the graft nephrectomy or both. But if you remember, the RMF for positive T cells was 7, means it's quite significantly high T cell positive cross-match in the serum taken shortly after graft nephrectomy. Afterwards, the degree of positivity became less. Fortunately enough, the current cross-match reported to be negative. The conclusion, this is a case of highly sensitized patients due to the transplantation itself or graft nephrectomy or both, with a historical positive cross-match but current negative cross-match. Of course, there was a clear indication for graft nephrectomy in this case. What about if it was asymptomatic and the graft failed over a long period of time? Will you still go ahead and remove it? This is the question I'm asking. Please think about it for a minute. So let us discuss the effect of graft nephrectomy on the immune system. Graft nephrectomy is not a risk-free operation. It is associated with significant morbidity and mortality, with complication rate around 20 to 30%, and the mortality may reach up to 11%. What a retained graft would do? Of course, we're talking about failed graft. A failed renal allograft that remains in situ may induce chronic inflammatory response syndrome. The patient will become resistant to erythropoietin associated with increased inflammatory markers, hypoalbuminemic, and maybe malnourished. Of course, to overcome this inflammatory response to a retained failed graft, we have to give immunosuppression. On the other hand, as I mentioned earlier on, graft nephrectomy is associated with morbidity and mortality and shouldn't be taken lightly. In addition to the morbidity and mortality of graft nephrectomy, which the operation itself, it leads to loss of residual function, so the patient becomes erythropoietin, and also we lose the residual diuresis, so it becomes dialysis dependent and vulnerable to fluid overload. Moreover, the higher level of HLA antibody sensitization after allograft nephrectomy could have a negative impact on the retransplant outcome. And this is one of the issues we are going to address in this lecture. What about the evidence regarding management? Fortunately, no randomized controlled trials have been performed to evaluate the benefit or the risk of allograft nephrectomy prior to retransplantation, and no clinical practice guidelines are available. Recently, few reviews discussing management of failed renal graft published. Also, the British Transplantation Society guidelines were published in 2023. All these publications and guidelines focus mainly on the role of dialysis and management of immunosuppression rather than graft nephrectomy versus no graft nephrectomy. So we can tell that the evidence is not strong and is not robust. Generally, the indications of graft nephrectomy very clear in case of life-threatening conditions. Indication is very clear regarding symptoms and signs of graft intolerance, or when we need to stop immunosuppression because of the side effects. But what about graft nephrectomy for asymptomatic failed graft? Before diving into this deep sea with uncertainty, let us discuss the techniques of graft nephrectomy for failed graft. The extracapsular approach, where there's no residual kidney tissues left behind. And this is usually for grafts transplanted recently and failed due to technical issues. The second technique, which is the intracapsular approach, usually for old graft, where we have to leave some residuation between patients without graft nephrectomy and patients who underwent allograft nephrectomy because of symptoms, and patients with elective allograft nephrectomy. Patients who underwent allograft nephrectomy because of symptoms had significantly higher PRA level than those with elective allograft nephrectomy or without allograft nephrectomy. 53% PRA versus 33% and 25% respectively. But this was the only study and not confirmed by a recent one. My impression is, as more donor tissue remains in situ after intracapsular procedure, it could be hypothesized that this leads to higher PRA level in these studies after intracapsular allograft nephrectomy, because This is the technique of graft nephrectomy in an old graft. Nevertheless, one study comparing both operation techniques did not find any significant difference in PRA level. I would like to remind you that they are using the old PRA rather than the recent Lemonix single engine beads. Let us discuss theories regarding the relation of donor-specific antibodies and graft nephrectomy. The first theory suggests that keeping a failed renal allograft in place triggers antibody formation due to continued exposure of the recipient's immune system to non-self antigens of the donor graft. Subsequently, this dictates graft nephrectomy. The second theory, called the sponge theory, which suggests that the anti-HLA antibodies that are formed because of sensitization are absorbed by the graft and therefore not easily detectable in the serum. After graft nephrectomy, this absorption is lacking, which may increase the serum levels of these donor-specific antibodies. Subsequently, this favors non-nephrectomy because the graft is absorbing the anti-HLA antibodies on each surface. Which one is true? No one knows. It's not clear. The antibody level is higher in the graft compared to the serum, but the same phenotypes. This may refute the sponge theory. On the other hand, a significant rise of HLA antibodies as soon as 5 days after the allograft nephrectomy could support the second theory, the sponge theory, but also could be due to severe tissue damage that leads to non-specific stimulation of the immune system and overproduction of anti-HLA antibodies. Of course, all theories need more examination and more understanding by future research. Another question comes to play here. Should we stop immunosuppression of a failed renal graft? Let us talk first about the advantages and disadvantages of immunosuppression. The advantages of immunosuppression include preservation of residual diuresis. The patient won't be dialysis dependent and vulnerable to fluid overload. Prevention of secondary adrenal insufficiency.
بسم الله الرحمن الرحيم. بنرحب بحضراتكم في السيشن الأولانية بتاعت transplantation. Our next talk about post-kidney transplantation emergencies produced by Professor Dr. Mohamed Salah.
To this prestigious conference, and I think over the first day and today lectures we proved that we are really, as mentioned yesterday by Professor Ashraf Hatem and His Excellency the Minister, we are the University of the Ministry of Health. So I think we're worth this title. Our talk will be about emergencies after kidney transplantation. A quick introduction. Of course, there is remarkable improvement of kidney transplant procedures, results, and everything regarding surgical and medical complications. Yet there is some morbidity and mortality that occurs post-kidney transplant. Moreover, in live donor kidney transplant, there is some problems or morbidity or mortality that may result for the donor himself. So we have the recipient and the donor. Other medical problems may interfere with the proper diagnosis emergencies. The living donor surgical emergencies. Well, mortality. There was a study in the United States of around 20,000 donors, living donors, between 1980 and 1991, and it showed that there was only 5 deaths with less than 0.03% death rate, which is a very minor and negligible, but yet it's a devastating event because the donor is a completely healthy individual who's going to do this noble action, and when this happens, it's really a big problem and a catastrophe. Of course, pulmonary emboli were the major cause of death, but none of the donors died intra or post-operatively due to technical problems. Mitas et al. In 2003 made a survey of the mortality and morbidity after living donation in the US, Bardo can around 10,000 donors, and there was only 2 donors died from surgical complications, and 1 was in a persistent vegetative state, all after laparoscopic nephrectomy. Therefore, according to Mitas et al., the mortality rate after laparoscopic nephrectomy is around 0.1%, triple the incidence of mortality after the conventional open technique. Chronic rejection is characterized by وانت بتعمل حاجة السلايد ده جه دخل مكان. طيب and pancreatitis are more common with laparoscopic nephrectomy. طيب surgical and non-surgical emergencies اللي بتحصل في recipients. أولاً, emergencies in the renal allograft recipient are defined as complications representing a significant risk on the survival of the patient or the graft. These emergencies could be classified as hemorrhagic complications, disorders causing early graft dysfunction, pathologies leading to late graft dysfunction, and surgical complications secondary to certain immunosuppressive medications. Hemorrhagic emergencies, يا إما primary, a secondary hemorrhage, rupture of the graft, rupture of mycotic aneurysm of renal allograft artery أو hematuria, with early graft dysfunction, whether due to volume contraction, acute tubular necrosis, hyperacute, accelerated and acute rejection, renal artery thrombosis, renal vein thrombosis, urinary leakage, ureteric obstruction, drug toxicity, and early recurrence of the original kidney disease. Late graft dysfunction, renal artery stenosis, lymphocele, ureteric obstruction, chronic rejection, and surgical complications leading to immunosuppression drugs زي السيروليمس بيعمل delayed wound healing, MMF أو mycophenolate mofetil, intestinal bleeding or perforation, especially when you do induction by ATG. Cyclophosphamide may lead to hemorrhagic cystitis. Primary bleeding اللي هو بيحصل في أول 24 to 48 hours. Most Often this bleeding occurs in patients اللي بياخدوا anticoagulation. If the hematoma is not clinically evident ممكن نعمل ultrasound أو CT عشان نشوف السايز ونشوف إذا كنا نفتح العيان ولا لأ. And treatment includes immediate surgery and blood transfusion as necessary. The bleeding site is identified and secured. Bleeding sites are the suture line عادة of the vascular anastomosis, the exit site of the tube, drain, and slipped ligature of the inferior epigastric artery. The secondary hemorrhage, this occurs usually later, a little bit في خلال أسبوع من إلى 10 أيام. It's the most dangerous لأنه الحقيقة usually بيبقى نتيجة infection. Rupture usually occurs in the first few weeks after transplantation. Predisposing factors: acute rejection, acute tubular necrosis, and renal vein thrombosis. It's very dangerous and very catastrophic event. This condition usually manifests as sudden acute pain and swelling over the graft. Ultrasound and non-contrast CT confirm presence of a large hematoma surrounding the graft. Rupture of the graft needs immediate surgical intervention with evacuation of the hematoma and identification of the site of bleeding. Usually it ends up by nephrectomy if the kidney is well. أما لو كانت الكدني well perfused, a release incision of the renal allograft capsule اللي هي بنسميها capsulotomy will decrease the intra-renal tension of the excessive associated edema of the allograft. On the other hand, النفركتومي يظل هو أهم شيء يعني if the graft was non-vascularized. Rupture of mycotic aneurysm of the renal allograft artery اللي بيبقى arterial mycotic aneurysm may develop as a result of sepsis with a few days to several weeks after transplantation. Where rupture of the mycotic aneurysm is a life-threatening condition and it ends usually with nephrectomy. Hematuria بتبقى عادة gross hematuria is يعني not that common لكن usually ممكن يبقى فيه microscopic hematuria usually related to the method of ureteroneocystostomy. عندنا نوعين الاشهر واللي بيعملوه معظم الجراحين بتوعنا ليش جاجوار، لكن في نوع اسمه البوليتانو ليد باتر، ويوجوالي الليش جاجوار الهيماتوما معاه اقل وهو ده non refluxing technique. Minor hematuria without clots is common in the first 2 days after transplantation and does not require treatment. It resolves spontaneously, usually نتيجة الدبل جي اللي متسابة جوه. Occasionally hematuria is severe enough to cause clot retention ودي ممكن تعمل urinary retention وبالتالي ممكن نعمل bladder irrigation. It's better to avoid continuous bladder irrigation and cystoscopy for fear of suture leakage. It is advisable to withdraw anticoagulants during hematuria. البيوبسي may complicate hematuria لان هو نفسه البيوبسي بيحصل بعديه شويه هيماتوريا، فمتبقاش عارف هو ده بسبب الهيماتوريا من العمليه ولا نتيجه البيوبسي. early graft dysfunction. Early dysfunction بتبريزنت بانيوريا او ليجوريا. الكوزز بتاعتها could be volume contraction اللي هي prerenal azotemia, acute tubular necrosis, rejection بانواعه, renal artery or renal vein thrombosis, urinary leak, urethral obstruction, drug toxicity, and early recurrence of the original kidney disease. الآن بيبقى diuresed immediately post transplant، بيبقى عنده بيجيب tremendous amount transplant بيوصل للتر واثنين لتر واحيانا 3 لتر per hour، يعني ممكن يعمل 30 لتر في اليوم. او لو هو cellular rejection يبقى احنا هنستخدم الانتي ثايموساين. انا يعني عمال اسكيب بسرعه عشان الوقت. الفاسكولار thrombosis, allograft vascular thrombosis is a serious complication that ultimately leads to graft loss. اليورينري ليكج اتكلمنا عنها من شويه. الدراج توكسيستي بالذات ماينس 3 وبيكملوا للعمليه. وفي بروتوكول تاني انا الحقيقه بفضله انه ببدا السي ان اي لما الكرياتينين يلاند تحت ال 3 ملغ بر ديسيليتر. نقابه الاطباء وخلاص احنا فتحنا باب الدبلومه وان شاء الله تكون اضافه لمصر كلها. شكرا جزيلا.
Thank you, Dr. Mohamed, for your very interesting talk. I would like to ask يعني the most common complication surgical ونون سيرجيكال كومبليكيشن على اساس ان احنا برضه بنميل الى التخصص بتاعنا. يعني ان يور بروجرام يعني الموست كومن سيرجيكال او نون سيرجيكال كومبليكيشن. والحاجه الثانيه برضه اللي عايز اسال عليها when to decide to do capsulotomy intraoperative. يعني مش عارف الحاجات ديت هتبقى بيوند يور سكوب ولا يعني ممكن حاجه
يعني جزء السيرجيكال طبعا مش هبقى احسن واحد بيتكلم فيه يعني. لكن في طبعا اساتذتنا، في الدكتور عبد العزيز وفي يعني اساتذه المعهد كيورولوجيست يقدروا يجاوبوا. انما احنا لو بنتكلم عموما statistically بقى بعيدا عن الجزء التكنيكال الجراحي، يعني اشهر حاجه طبعا الووند بروبلمز، الليمفوسيل برضو من الحاجات المهمه قوي اللي بنشوفها، والهيموريدج اوف كورس. ده بالنسبه للسيرجيكال. للنون سيرجيكال الحقيقه الريجكشن ناو دايز اصبح قليل قوي، يعني مع البروبر HLA ماتشنج والكروس ماتشنج باللومينكس والفلو سايتومتري سوري والاتش ال اي ماتشنج والانتي بودي ديتكشن باي لومينكس، اصبح يعني ما يصحش ان عيان يجيله مشكله بسبب الحاجات دي، الا بقى لو حاجه ان ما زال هناك في الايميونولوجي